You just have to flood a country's public square with enough raw sewage.
And if anybody is lying here, Senator, it is you.
Once they lose trust in their leaders, in mainstream media, in political institutions, in each other, in the possibility of truth, the game's won.
I'm John Davidson with Broken Truth, and today I am with Dr. Sheila Furey from Virginia, and you are a child psychiatrist, correct?
I am. Been in practice for over 30 years.
Oh, wow. So, doctor, would you be able to speak with some expertise in the area of family and children's psychology?
Correct. Yeah, as a child psychiatrist, I evaluate children, their parents, and the family situation. And in particular, I have an interest in children who have medical complications. And so, or who have major medical illness in the face of psychiatric illness. So this is an area of interest to me, and this case has really caught my eye.
Yeah, so the case that we're discussing today is the Joy Zuraff, Kenlee Zuraff case, which, by the way, you can catch up on this at freekenlee.com. That's free, KENLEE.com. And a couple of issues in what's publicly available about this case. One was allegedly the DCF, which is Department of Children and Families in Florida, their staffers had consulted with a nurse practitioner who somehow diagnosed the mother, Joy, with Munchausen by proxy without ever actually speaking to her. Could you explain that diagnosis and whether or not that's a normal procedure for diagnosing a patient?
Well, the exact diagnosis is fictitious disorder or fictitious disorder by another, okay? And so what we are having is a person who is deliberately taking actions to falsely present a medical illness by either making up the symptoms or creating signs of illness, and that they're doing that for some psychological gain, right? And so in this case, I have not evaluated the mother or the child. So this is a typical evaluation of an adult that you suspect may be contributing in some manner to the harm of the child. So you would evaluate the child, but you would also extensively evaluate the mother or the father or whoever is the suspect in this case. And you would want to understand from their perspective what is going on. And in particular, you would be looking at are there signs of discrepancy between what the mother says and the medical condition? And in this particular case, the child has been diagnosed with cystic fibrosis. There is no question about the diagnosis. This child has a severe medical illness, and it has significant complications. And it has complications not only from the illness, but also from the chronic medical treatment that occurs. So many of these children are on long-term antibiotics. They are on other medications to protect other organs in their body, primarily the pancreas and the liver, and trying to make their digestive system work as well as their lungs work. And so it's a really complicated case. And it's also, when I was in my early training, the life expectancy for children with cystic fibrosis was very poor. And with a lot of that time spent in the hospitalization. The important thing when you're treating a child with complicated medical illness is to listen to the parents. Parents are experts, and parents, and particularly moms, can know when a child is exhibiting very small changes in their behavior But that small incidental change can mean if I don't act now, there's going to be a hospitalization. And so in my years of training, it's been really important for me to really listen to the parents and carefully listen to the parents and understand all of their questions, their concerns, and particularly about medications and understanding, helping the parent understand the risks, the benefits, and the alternatives of medication. And what my understanding of this case is that the mother was offered a medication and she was extremely concerned about the risk of that medication. She was not uh, giving false signs or symptoms to the doctor about illness about the child. She was not doing anything, in my understanding, to cause the child to have symptoms. All right. So if a child has cystic fibrosis and you're giving them inhalers or other medication, is she not giving them medication as prescribed? This was a case where she was offered a new medication and she was concerned about the risk of liver failure. And that's a very valid risk in this case. And what I've read about the medication, there was a study of 78 children between the ages of 6 and 12. If she was This was discussed when she was age 5, because I understand that she is now 7, and this was 2 years ago. She was, not even in the study criteria because she was 5. Additionally, liver concerns, pancreatic concerns are major, concerns with this medication, in which they ask that the liver function test be monitored with the medication on a very regular frequency to make sure that the child doesn't experience liver disease with the risk of liver failure. If this child experiences liver failure, she may need if she experiences liver failure, will need a transplant. That's a significant risk. And with any medication, you want to be very careful and walk with the parent down this road so that everybody's on the same page and that you're willingly accepting a risk that is very valid in this case. And so a parent's hesitancy, particularly at age 5, to say, well, maybe let's hold off, let's get more data before I make this decision. Let it be on the market for a longer period of time. I don't like to prescribe any medication that has only been on the market for a year, and preferably 5 years before, particularly with children, because the risk of death and harm is significantly elevated. And because they're just, they're little people, but they also have very fragile metabolisms. And this is a case where this little girl has a fragile metabolism simply because of the underlying diagnoses. And so the mother is expressing concern. Concern is not a fictitious disorder. It is not a fabrication of signs or symptoms of illness. And there's no gain for this mother in any way, shape, or form. In fact, she has suffered traumatic losses, and traumatic losses not only to her as a mother and to the child, but to the siblings. This family has been completely torn apart because of the actions of someone not carefully looking at, or it appears that way, looking at what the mother said and what her concerns are, and being able to validly acknowledge her concerns and walk with her as she makes this decision, rather than simply coming to a conclusion that she needs to be removed from the mother.
Um, Thank you, doctor. That seems very clear. So basically, what you're saying is that the mother could not have invented or, you know, fictitiously manifested cystic fibrosis because it's not possible to do such a thing, right?
But the child has been diagnosed and for a long time has been treated for cystic fibrosis. Okay. And so if that is the case, what you're looking at is just a difference of an opinion about how treatment is going to proceed. And there are often times where there is a difference of opinion between a physician and the family, the physician and the patient. And these are really difficult decisions. And often you want to take time. I have prescribed medications that have black box warnings and REMS warnings, and I am very clear about when I'm walking through that process with the family about looking at the risk, the benefits, and the options, and that if they begin down that road, because they want treatment and other treatments have failed, to say if at any point you decide that you no longer want to go down this road, we can stop. And
So
so
yeah,
go ahead.
can I ask, are parents allowed to reject medications doctors want to put them on, or their children on, even, well, in a general situation, are they allowed to reject medications?
Yes.
Um,
And it's unusual, and there are times, and when in particular, one of the is certain religious groups do not permit blood transfusions. All right. And if a child emergently needs a blood transfusion in order to save their life, there may be a time when um, the state would step in and say, "We understand your religious feelings about this. However, because this child is such and such an age, and we feel it, even though that you have these religious objections, we feel it's in the interest of the state to give them what we know is a life-saving blood product with what they determine is little risk." In this case, it's a new medication which has only been studied for a short amount of time, and there are significant risks, particularly for this child, a risk of severe liver harm, but also risk of significant drug-drug interactions. So it isn't just the drug itself, it's all the other medications because children with cystic fibrosis are often on multiple medication regimes. They're often they can be on and experience the use of a lot of antibiotics. And so, what if this drug is going to interfere with a potential antibiotic that they're on? Those are all concerns. And one of the biggest things with cystic fibrosis and them getting frequent pneumonias is that they become drug resistant. And so to antibiotics. And so the number of medications that it takes to treat a pneumonia when they're in the hospital often increases. And so again, it isn't just the single drug in isolation, it's this drug in the presence of all the other medications that the child is currently taking.
um, back to just the Munchausen diagnosis. According to a document that the mother wrote before she was placed under a gag order, so she's not allowed to speak or tell anything about her story to the press, um, or anyone, I guess. Uh, she stated in this document, DCF had their, let's see, let me get DCS investigators. Sorry, this is a long thing. Okay, DCF also had their nurse practitioner say I have Munchausen by proxy and closed the investigation without ever talking to me. Is it possible to diagnose a person without ever speaking to them with that or any diagnosis, especially that's one that's provided to the court as evidence?
You could give a medical opinion, but I would be concerned about a nurse practitioner giving a medical opinion who is not a child psychiatrist, who is not a psychiatrist, and what is their experience in dealing with this diagnosis of fictitious disorder or Munchausen's by proxy, and that you cannot definitively diagnose someone if you've never evaluated them. That's unethical.
So, in that frame, if it's unethical, could that nurse practitioner lose his or her license?
I think that there could be sanctions against that person. I think it's something that you could report if you're giving a diagnosis to someone that you have never evaluated. So it's not just an opinion about what other people have written, but you're giving a specific diagnosis of someone that you have not evaluated. I think that that's something that the board in Florida would want to look at.
Ultimately, this seems as if DCF has overstepped dramatically. One of the judges has been off the case for some reason. We're not sure why, but that's always a questionable action when a judge is replaced. And the gag order was placed on the mom, which again is unusual that a court would want to silence a parent fighting for their rights. Do you think that this case, based just on the information that you've seen, merits the mother having her parental rights? They call it a TPC, a termination of parental. Oh, TPR. Termination of parental rights is going into effect on Monday, or the court is going to try to initiate that Monday. Do you think that this evidence justifies that?
Well, I have participated in termination of parental rights cases, and they are very tough cases. And they are cases in which I have seen or has been documented significant abuse over significant periods of time. It is very serious matter, and we should not, and the court should not take lightly termination of parental rights. And in fact, they should go above and beyond to make sure that the evidence is accurate, correct, and that they have a full understanding of all of the circumstances around. And it does not look like that has happened in this case. And you would also, even in cases where there is significant abuse that has been documented, I have been involved in cases where those have dragged on for multiple years. And it's in an attempt to give the parent every opportunity to correct whatever actions that led to the abuse so that there can be a reunification of the child and parent. However, it does not look like any of this in any way, shape, or form, and in the face of there's no documented abuse.
Correct. So, in terms of hospitals, um, are doctors a little trigger happy in reporting parents to Family Children Services? Or maybe my better question is disagreeing with a doctor's treatment recommendation grounds for contacting DCF?
Those that have to be looked at in multiple ways, and it has to look at the circumstances and what is the risk to the child. But just a simple disagreement about a treatment plan for a child, I don't think is grounds for in Virginia, it's, calling the Child Protective Services. And what the mandate is for physicians and for other people in authority, for teachers, et cetera, is that if there is suspicion, so we don't have to prove it, okay? But if there is suspicion of harm to the child or significant risk of harm to the child, we have to file, okay? So so does that make some people trigger happy? It may, okay? But you have to look at all of the circumstances and take the time to evaluate the circumstances and is there imminent risk to the child, right? And I would say that most doctors are on such a time crunch that often this gets turfed to people who aren't familiar with the case. And so it may be turfed to somebody in the office. So as a physician, you may turf it to the social worker or someone else to dig a little more. All right. But the ultimate responsibility is with the person who files it. So as a physician, if I'm going to file, you know, a concern that the child is at risk for harm, I'm going to take a lot of time to do that. I'm going to be calling multiple individuals. It may take hours to do that. And so
Right.
I'm not going to take any of that lightly. So this is not something that is done in a 15 or a 30-minute appointment. This is going to take time, and it doesn't mean it has to be done instantly unless there is imminent risk. If you feel there's imminent risk, absolutely. But this is a situation where you have time on your hands. This that you could take the time not only to meet with the mother, the father, the other siblings, and try to figure out what is going on and how we can proceed in the best mechanism to help this child.
Um, is a report to DCF, even one that is closed and considered unsubstantiated, is that considered a scarlet letter? Does it follow parents around and torment them for the rest of their parental life?
It can. And so you have to look at what were the reasons that it was unfounded. And so if it was unfounded because there was no evidence, um, it was a false complaint, or whatever evidence was presented did not meet any standard, then that should not be held against the parents. Okay. If it was not substantiated, but they wanted to put a program in to increase services in the home or increase therapy for child and family. And so there was a plan of action that occurred after an unsubstantiated ruling of child abuse. That might be a different situation, but everyone has to be looked at individually.
Um, Final question. What kind of psychological issues will a child that has been forcibly removed at gunpoint or, well, by armed officers and CPS agents, what, uh, what kind of psychological damage will the mother be looking at if she gets her child back?
I think it's important. This is a really important question. And I think the harm is substantial. If this child um, has, if is fearful that they're never going to see their mother again, right? And in some cases, that is the case. They can feel abandoned, all right? And because the most important figure in their life, their mother and their father, is no longer present to them. And can they begin to trust another adult to protect and care for them in the manner in which their own biological mother and father did? And the chances of that, I mean, yes, it occurs that adopted parents are wonderful parents, all right? But it's still, they have that longing, inherent longing for their own mother and father. And so, and in these circumstances, I think it creates lots of confusion for the young child because they don't know why they were removed. All right. And so, if they're told, for instance, that mommy was bad, well, then what does that mean that mommy was bad? If mommy was just um, concerned about the medication and had concerns about the treatment, does that make mommy bad? So not only is there trust with other caregivers, there's trust when there's reunification, and how to build that trust back. It'll be a very long road.
Dr. Sheila Furey, thank you so very much for your answers to my questions. And I really appreciate your time. Have a wonderful day.
All right. Thank you very much.
Thank you.
Okay. I didn't decline any medications. I declined getting Toby until she was getting an antibiotic. She was getting one. I said I wanted to do the cultures because that's such another strong antibiotic.
Yeah.
And I wasn't declining her oxygen. I just didn't want her to freak out on them and be like a lot of trauma for a little kid, right? You're getting potted. She doesn't like her nose touch. And so I said, can we try a different way of her getting the oxygen? They said I was denying it. I never denied the oxygen.
What about the CF meds that Dr. Sindel wanted her on, the
Tricafta?
Yeah.
So my daughter was on Orkambi when she was little.
Totally different medicine.
It is, but it's
Totally different medicine, so that doesn't come into play. Why were you denying her the other one?
I said because of her being on Orkambi, that the side effects of that, I wanted to hold off until we knew she absolutely needed it. Because I didn't feel like we were there, and I said, I just need to know, like, if I want to see if her little body can heal after all this. Like, looking at her lungs right now, she's got a bunch of stuff going on. She's got coronavirus, she's got pneumonia, she's culturing staph, she's culturing cynomolgus. Like, can we see if in a few months her lungs clear up? And if they're not, then we discuss it.
Why were you refusing abortions?
I wasn't refusing x-ray.
Okay.
And they said that, like, after they did the first x-ray, and then they did one 2 days later, that one improved. They did another one 2 days later, that one improved.
We are taking Kenlee with us. Okay? Now, you can handle this one of two ways. You can show out and you can act a fool and you can make this difficult.
Or can my
Or-
friend Jamie take her?
Stop. Let me finish. Don't interrupt me. You can show out and act a fool and make the situation worse. Or two, you can calm yourself, ask your questions, and then help us get her stuff and walk her to my car. The option is yours, but either way, make no mistake, she's coming with me tonight.
Why?
Because of the treatment you've refused and because of the doctors.
I'm not
and
refusing treatment.
Don't interrupt me. That's twice. That's one of my pet peeves.
That's the cop in you. I don't like being interrupted. That's the mama I've been interrupted.
Because of the treatment you've refused and the condition her lungs are in, you have been told repeatedly by doctors that she is going to be needing a lung transplant at a young age because of your refusal to give her medication to address her CF. I applaud you for trying to do the natural way. But with this disease and your 39-year-old friend, shame on her. She knows that this affects every individual differently. Because, see, I've had to get spun up on this disease. Every individual differently. What might not work for her might work for your daughter. What might not work for another 5-year-old might work for your daughter. So you can't take the advice of somebody just because they have CF. That's not smart.
I'm not. I called her old doctor and I'm asking them for a second opinion.
Okay, well, we got 3 opinions. We've got South Dakota, we've got Nebraska, we got Sacred Heart, and we got Dr. Sindel. Those are all the opinions we have. Do you understand? These are all pulmonologists that have given their input saying,
If I go on Tricafta, can I keep my daughter?
I don't know.
So once this is punctured, it has to be refrigerated.
Okay.
So it's 2 milliliters. There's 4 milliliters in there.
Okay.
And then
Is this a shot or does it go in the machine?
no, it goes in the nebulizer.
Okay.
It takes 2 milliliters of that with 2 milliliters of this.
Okay.
And then once they're open, they have to go in the refrigerator. And then if I give you a bigger bottle, if I find a bigger bottle, they're only good in the fridge for 4 days.
They just clear up when you're an adult. Just went away as an adult.
Have to be refrigerated.
Okay, sounds good.
You need me to write this down?
It would help if you could.